It's 5 p.m. Italian time, so it's the perfect time to get started with all the 4x4s involved in today's educational trip that, as always, starts with the spectacular image of the Italian pavilion at the Expo in Dubai. A spectacular pavilion made by 3 upside-down boats, as you can see from the roof, a metaphor, as we are used to say, of the journey we are all doing around the world, and that will lead us to the spectacular venue of Dubai for connecting experts, informing patients in evidence-based venous lymphatic communication. You can see, for example, the 2 pavilions, one of Spain and one of England, and good luck, England, for the special day in representation of the English language we will use today, broadcasting from West Indies, like every Sunday. As you know, every Saturday we broadcast from Central America in Spanish, and I'd like to take this chance to deeply thank all the colleagues and friends involved in yesterday's successful gathering. You can make questions in whatever language in the question and answer box. They will be answered live or in written forms based on the time allowance. And remember to rely on our organizing secretary if you're interested in the international CME credits and the attendance certification. And I could not be happier than today in announcing a special edition with the special friends and colleagues, because there is a little bit of LATAF in today's initiative that is broadcasting indeed from Central America and West Indies, but also bridging, as always, with Africa, thanks to this project. So I will deeply thank all the colleagues involved in this educational bridge. This bridge is particularly important today because it is addressed to internal medicine and general medicine colleagues following the reading of papers like this one, showing us that whatever patient we are going to receive in our office, whatever specialist we are, we have more than 50% of the chances of having a patient presenting some form of venous and lymphatic complaint. Now, always again, following the evidence-based data, we have less than 50% of the general practitioners' colleagues really knowing the guidelines and referring the specialist to the specialist even in the most advanced stages or in the early stages to be recognized. For this reason, we are all enjoying this educational trip of the 4x4, for which I'd like to deeply thank, in particular, the colleagues from West Indies and Central America who got started together with 3 other special colleagues and friends that I would like to get recognized for their work in the preparatory material of this project. I'd like to deeply thank also Servier for having allowed this educational journey and having believed in an unbiased support to an approach to the general and internal medicine world. As always, nothing would have been possible without the ones I consider family and, of course, huge colleagues and friends of many of us, Professor Bottini and Professor Chi. Oscar?
Welcome, everybody. Hope you enjoyed this educational proposal called 4x4, today here in English to West Indies and all the world. Thank you.
Thank you so much, Oscar. You have been as fast as Willie would have been, but unfortunately, Willie today is misbehaving. As you can see, he's enjoying his vacation time, so he sent us a video message.
Dear friends and colleagues, I know you certainly have enjoyed last week's 4x4 excellent program. Unfortunately, this week, I am going to be out again. I'd be stuck on a little island in the middle of Pacific. It's an island that you probably never heard of, which is Hawaii. And I'll be back, in a couple of weeks. And I'd love to see you all when I come back. So with that, I am sure that you're going to enjoy another excellent program on July 10th and 11th. Ciao.
So we will see if we will admit Professor Chi back in the team, considering this misbehaving, but jokes aside, we deeply thank him for being always in the first line in education promotion. I know that talking about line, we have some issues with the connection from Italy, from Professor Danese, that would have liked to have with us to represent the venous lymphatic ward, but since we have the ones we consider cousins, so the French colleagues and a special friend of ours and a huge figure in the field, Professor Josnen, I will now pass the mic to Professor Josnen for the opening of honor. Unmute yourself, Matt.
Yeah. Good evening, everyone. Thank you, Sergio, Oscar, and for inviting me. Diagnosis of lymphatic and venous disease requires thorough medical examination to identify the underlying problem and to exclude other possible causes with certainty. This medical examination will be performed by physicians with expertise in lymphatic and venous disease. After specialist imaging procedures may then be necessary to obtain additional information like ultrasound, lymphocytography, MRI, etc. Once the diagnosis has been made, the patient must be cared by a specialist teams who will ensure the patient follow-up over time. It's imperative that the training of physicians integrates the necessary basis to allow all physicians to evoke the diagnosis, but also to refer to specialists the patient who need it. However, the delay is still present, and in France, there are significant differences from one territory to another. Depending on where you live, you will not have access to the same structure, and the training of doctors in this field will remain unequal. It's imperative that we continue to raise awareness on this subject, and this is done through conferences like the one organized today, which allows the recognition of this entity much more precise. Thank you.
Thank you so much. And I saw also Dr. Danese coming in. So if Massimo is connected, we will welcome him, but I see that there is still some connection issue. So we will move forward with the opening from the Internal General and Medicine representative, Professor Singh, who is the president of the College of Family Practitioner for the Tobago chapter.
Good morning, good afternoon.
Oh, we are having a good connection live, so please go.
Yes. Good morning, good afternoon, good evening. I am Dr. Kathleen Sangster Singh, President of the Caribbean College of Family Physicians, Tobago chapter. I bring you greetings on behalf of the chapter. Welcome to the second webinar in the 4x4 Medical Education Program focused on venous and lymphatic diseases organized by the International Venous Lymphatic Network International, VWIN Foundation, in collaboration with Survey Central America and the Caribbean. This program has been created to promote interaction and teamwork between internal medicine and family medicine doctors with venous lymphatic specialists to promote the best management of patients with venous and lymphatic disorders. Last week, Sunday, there were excellent presentations where we learned about evidence-based venous lymphatic principles. Today, we are looking forward to learning how to make the correct diagnosis of venous and lymphatic disorders from a panel of experts. Enjoy the webinar.
Thank you so much, Dr. Singh.
Dear Sergio, I'm here.
Wait a second, yes, Massimo. Wait a second, Massimo. Don't be too excited. I know that today is a Euro Cup. Wait a second. I know that you're excited. I just wanted to say thank you to Dr. Singh for the involvement with the internal medicine ward, and now the word goes to Professor Danese. Massimo, a quick
Thanks, Sergio.
opening.
I'm truly honored to represent Italian Fable Lymphology World in collaboration with General Internal Medicine. I would like to thank organizers to this international event. Special thanks to you. Fable Lymphology is a branch of internal medicine that deals with the diagnosis and treatment of venous lymphatic pathology, ranging from superficial venous insufficiency to deep venous thrombosis to primary and secondary lymphedema. The main goal, or better, the mission of this event is to create a perfect synergy between internal medicine and Fable Lymphology. Thank you for your attention. I wish you good work for all. Thanks, Sergio.
Thank you so much to Professor Danese for always presenting properly our country. And now we finally get started with the scientific part. We know that this module is dedicated to the venous diagnosis with 4 different talks. We will start with Dr. Pittman, a huge expert who needs no introduction, a dear friend of many of us. He will talk about clinical consultation state of the art. We are enjoying his lecture here, and then we will have him live with us.
Thank you, Dr. Sergio Giannassini, for the invitation and honor to be discussing state-of-the-art in clinical consultation. My name's Dr. Christopher Pittman from Tampa, Florida. These are my disclosures. ED Etiology of venous disease. Heredity is far and away the leading cause. I have rank ordered the leading causes of venous disease roughly. Genetics weakens vein walls, veins enlarge, and valves leak. The prevalence of vision correction with glasses and contact lenses approximates that of venous disease, about 60% of the US population. If you're a lady and have ever been pregnant, it's a very big risk factor. In fact, venous disease is the only disease caused by parents and children in a lady. It's a joke, but true. The primary cause is progesterone. In fact, those who develop venous insufficiency during pregnancy, 70% will develop it within the first trimester. Lesser causes are enlarged uterus and increased blood volume. Occupations requiring prolonged standing or sitting contribute to lack of calf muscle pump action, and there's sustained venous hypertension, which damages vein walls and valves. As we age, everything sags, including our veins, which leads to problems with our veins and their valves. Obesity isn't good for anyone, but certainly excess weight causes venous hypertension that damages vein walls and valves. Trauma of any kind, leg injury or surgery, damages veins and lymphatic vessels, causing or exacerbating existing vein disease. Fundamentals of diagnosis of superficial venous insufficiency. No single symptom, sign, or test is appropriate for patient selection for treatment. Of course, history and physical exam is important. Many symptoms may be present, and it's important to ask questions about location, distribution, character, quality, duration, frequency, severity, intensity, aggravating, provoking factors, alleviating factors. As to signs, examine your patient carefully. Touch your patient's ankles. More about this later. Of course, an ultrasound exam is fundamental to the diagnosis of superficial venous insufficiency, and we'll leave that to other lecturers. However, if an ultrasound is negative and compelling signs and symptoms of venous disease are present, repeat the ultrasound. Additionally, assess edema during routine venous ultrasound testing. More about this later. A monitored hose trial is often discounted by venous practitioners. We feel it's very important. More about this later. Of course, all of us are familiar with the symptoms and signs of venous disease. Symptoms may include itching, heaviness, tiredness, aches, pain, tenderness, burning, cramping, night cramping, restless legs, even numbness and tingling, perhaps other symptoms. Vein disease signs, or that which we see, include spider veins. Spider veins below the knees or involving the ankles almost always have a medical component. Bulging, varicose veins, ankle swelling, skin discoloration, skin thickening, bleeding veins, ulceration, or other signs. Vein disease is often unrecognized, especially by primary care physicians. Many patients and their doctors simply don't recognize that vein disease may be the cause of their leg symptoms. Only about 50% of patients with lifestyle-limiting vein-related symptoms will have obvious, visible signs of vein disease. Of course, ultrasound exam shows objective evidence of vein disease based on diameter and flow direction. There are many benefits to a monitored hose trial. However, caveats include the use of high-quality, internationally recognized hose brands that are certified, graduated, expertly measured, and fitted. We recommend a patient wear a hose 2 days on and 2 days off for 1 to 3 weeks to evaluate their symptom response. Patients with even marginal symptom improvement in compression hose likely have vein disease. Monitored hose trial benefits are many. A monitored trial helps make the diagnosis when little or no signs of vein disease are present. Hose trial may help set patient expectations about likelihood of symptom improvement post-treatment. A hose trial helps patient understanding and compliance with your treatment plan. Hose trial helps discern venous symptoms from concurrent neurologic and/or musculoskeletal symptoms such as sciatica, arthritis, peripheral neuropathy, and others. If no symptom improvement after a hose trial, it may still be reasonable to offer treatment because Symptom improvement after definitive treatment is often better than wearing hose alone. Because the risks of treatment are low and patient improvement may be life-changing, it's reasonable to treat one leg and assess symptom response over weeks or months and compare with the opposite untreated leg. An opposite leg often serves as an internal control. Patients with symptoms more typical of neurologic and/or musculoskeletal problems may yet have a venous etiology. Not all patients follow a medical textbook. Many patients and their doctors ascribe symptoms to neurologic and musculoskeletal etiologies when in fact venous disease may be the culprit. Is my patient C2 or C3? Detection of ankle swelling. Many patients have ankle swelling that they and their doctors do not recognize. It is impossible to assess swelling edema without touching your patient's ankles. Firmly compress the tibia bone using your second through fourth fingers just above the medial malleolus for 30 seconds. If there is any epidermal or dermal impression, the patient almost certainly has edema that can be confirmed on diagnostic ultrasound. We believe edema is often underdiagnosed and far more patients are properly classified as C3 rather than C2. An abstract from our team is pending submission to the 2021 AVLS Annual Congress demonstrating the high correlation between the clinical detection of edema as described above and the detection of edema using ultrasound. Clinical consultation summary. Venous disease is very common and often overlooked by primary care physicians. Diagnosis requires evaluation of a constellation of findings, not just one finding. When faced with compelling signs and/or symptoms of venous disease and the ultrasound is negative, repeat the ultrasound. Monitored hose trial may help make the diagnosis or refine the diagnosis. In many cases, venous edema is more common than physicians realize. Thank you for your attention, and thank you again to Dr. Sergio Giannassini for the invitation and honor. Please stay connected with me through email and LinkedIn.
And with this, we deeply thank Dr. Pittman. We will enjoy his presence live right after my talk dedicated to venous Doppler, what is to be assessed and how. And I deeply thank Dr. Pittman for being another inspiration of bridge building, because he is now creating a group that is looking forward for collaboration with Central and Latin America. So I'm sure we will have many other things to share. Now, it is my pleasure to talk about what is to be assessed and how, of course, in my opinion, when we are doing venous Doppler, addressing in particular the internal medicine and general practitioners colleagues. These are my conflicts of interest. I think this is a very important topic, and I think this, since I've been reading this paper in 2016, that is showing us how many different practices there are in the general practitioner use of the ultrasound, pointing out in this paper on the difficult aspects that there are in terms of financial aspects rather than the time use and lack of skills, because indeed we have so many devices that are offered nowadays also into the general practitioner office with these new, for example, app even allowing you to use the ultrasound by your phone. But as per this very interesting paper by Stasi and other colleagues, there is indeed quite a diagnostic consumerism, I would say, that is not followed by proper training, for which it is very important, I think, to rely on huge figures like the ones we have here in today in the person, for example, of Professor Ta, to really learn how to use the ultrasound properly. Because even in the general practitioner office, the ultrasound can be as important as a stethoscope, as you can see from this paper of Ciso and Almiral, who showed that with the proper use of the ultrasound in the general practitioner office, they were able to manage better the important topic of the abdominal aorta aneurysm. As we said at the beginning of this webinar, indeed, we have 1 patient out of 2 entering the general practitioner office presenting potentially some venous and lymphatic disorder. And when we are talking about disorders, we are talking in this case specifically about venous hypertension in the lower limb. And if you remember the other module lecture about the physics laws and the pathophysiology, indeed, when we are talking about pressure, we are talking about the golden rule that is moving the flow. In order to create a flow in between 2 points or a reflux in between 2 points, all we need is a pressure gradient. So in order to try to make it easy and approachable, quite a difficult topic, I would say that we could simply think about our, let's say, Italian leg in this case, and again, good luck to our nation for tonight Europe Cup. But we could just have to know perfectly well the network of veins that we have inside our lower limb, and always remember this golden rule, that whenever there is a reflux, we must identify not just the reflux, but the leaking point and the re-entry point. Now, for example, the leaking point can be an incompetent saphenofemoral junction, and the re-entry point can be a perforating vein along this GSV, so along this great saphenous vein, or along an incompetent tributary. So remember just the Poiseuille law. We don't want to know if there is a reflux along the saphenous vein only. We also want to know where there is the leaking point and where there is the re-entry point that is indeed creating this pathological pressure gradient. We have, of course, to make sure that there are no obstructions or refluxing on the main road to the heart. So, of course, we want to have a correct report of the deep venous system, first of all. And we also want to be sure that we don't have leaking points from the floor above the one of the lower limb, which means the pelvic floor. Consider that also thanks to the collaboration of Professor Lazarashvili and on the Georgian Association, we focused deeply on the topic of pelvic venous disorders. And it is also a topic of gender equality, as Professor Taha will show us next week in a dedicated project to female awareness. Because indeed it is definitely a frequent condition, the one of having varicose veins that are actually coming from the pelvis, not directly from the saphenous trunks, for example. So you really want to be sure that all is fine in that region. This is a paper of our group that is looking once again at the venous hypertension when you have a failure of the valve right above the saphenofemoral junction. Now, a common mistake is the one of focusing just up to the level of the leg without really thinking what's going on at the inguinal level or even above. What we demonstrated in this paper is that if there is an incompetence of this tract, we have an odds ratio, so a risk that is going up to 5 times of having a pathological pressure gradient that is facilitating recurrences in the district of the saphenofemoral junction. And in this other paper, indeed, we showed how in these cases we usually prefer mini-invasive surgery with the titanium clip apposition rather than other techniques. We also demonstrated clearly with our hemodynamic group following the studies of Cappelli and also other colleagues who investigated the topic, how our sample volume should never be just at the saphenous arch, because in almost half of the cases, we are actually having a saphenous arch that is incompetent, but with a competent terminal valve. So the report you want to read about an ultrasound should always include the evaluation at the femoral side of the terminal valve with an evocation of the flow done by 2 different maneuvers, the ones of Valsalva and the one of the compression relaxation of the cuff. Then, of course, you want to have a deep look at all the different saphenous trunks. And remember, of course, that we don't have just one saphenous vein. We have also the anterior accessory saphenous vein and the small saphenous vein, and actually also other like the Giacomini vein we wanted to report. In these other 2 papers we published, we looked at the different velocities inside the different networks. And we pointed out how with different maneuvers, you can have different results in terms of the flow that you are evoking. You see, for example, at the iliac level, at the femoral level, the posterior tibial vein level, and the tributary level, you're going to obtain different velocities if you evoke the flow by a compression relaxation rather than an active dorsiflexion. So you always want to report also the kind of maneuver you're using to perform this evaluation at the ultrasound. And of course, then you want to have information about the tributaries that are in reality then the varicose veins we usually see, about their reflux, but again about their source and their re-entry point. Indeed, focusing on the perforating veins is of fundamental importance to really understand if this perforating vein is pathological or is just actually simply balancing the pressures that are inside the system. Now, assessing the perforating veins, and this is quite technical, so I will just go fast on this, and you will have the opportunity to enjoy the longer version of these talks in the recorded material provided in the platform. It is important to you look at these perforating veins because with a simple digit compression of an incompetent tributary, you can change the pressure gradient and test these perforating veins to see if they are indeed bringing the blood back into the deep system or if they are pathological. But we can discuss this in case you're interested in more advanced lectures that we will provide on the topic. I think that the main message here is that before asking for brand new probe or brand new tools, we should really go back to the proper educational courses and use at best this important device. Another important thing we wanted to detect, of course, is the eventual thrombosis. There will be a dedicated lecture on this. So I will simply say that if you land in Rome and you like to come and visit me in the University of Ferrara, if you spared the great saphenous vein, you can take these perforating veins and just travel in a, let's say, bypassing road. So you understand the importance of these perforating veins that are connecting the superficial and the deep system. We indeed made what I consider the most important investigation of our group on the topic of perforating veins because they are usually considered veins that are draining from the surface toward the deepest compartment. But in reality, this is happening because we are not really having the tools that are allowing us to deeply investigate these vessels. Usually we use the color, that is a qualitative measure, or we have the sample volume in one single spot that is dependent by the tortuosity of the vessel. By using an advanced software that is a multi-gate analysis that is giving us the net flow direction, what we demonstrated is that the majority of perforating veins that are usually considered incompetent, so pathological, because there is an outward diastolic flow lasting more than 0.5 seconds, in reality are presenting a net inflow inside the deep system. So they are simply balancing the pressure, as we were saying before. And indeed, in this I will quote Aristotle, who was used to say that the aim of art is to represent not the outward appearance of things, but their inward significance, meaning that we shouldn't look at the perforating veins just for their outward diastolic flow, but also for their inward one. I will conclude saying that sonographers are fundamental in our everyday practice, but they might look like all the same, but surely they are not. It is very important to rely on a proper assessment. So you will have the opportunity in the recorded material to have a look at all the suggestions we are providing for proper assessment. I will just go briefly mentioning them. As you can see, we reported over here the importance of the time of the day in which you're doing the scanning, the position of the patients. Of course, you want to have the patient standing. You have to report how you elicited the flow. You want to assess all the different segments we touched in this talk. In case of reflux, we want really to specify where the leaking point and the re-entry point is. We always wanted to report eventual presence of lymphedema and also of arterial disease and also of eventual pelvic escape points. And we don't want to forget to look at the leg of the patients in total because there could be also alteration of the posture and also of the foot venous plexus drainage. So my suggestion is to perform a proper ultrasound evaluation. If you are in a general practitioner office, of course, if you detect a reflux, immediately go for a specialistic evaluation. If there is no reflux, evaluate carefully symptoms and signs, because a lot of time you can still have venous hypertension not detected by the ultrasound. So you might take already actions eventually with the proper measures, so an adequate lifestyle, validated venous active drugs, validated graduated compression, for example. Because indeed the disease is starting very early at the microscopic level, moving to the macroscopic one, and it really requires a teamwork of different specialists, including, of course, in the first line, general internal medicine. For this, I like to deeply thank once again all the ones who have believed in the teamwork dedicated to this project, and to the ones who are believing in the fact that evidence-based data is fundamental, for which everybody is co-working on this project dedicated to reporting eventually encountered fake news. And on this, we move forward, and it is my pleasure to introduce Dr. Patel, that is in representation of Barbados General Internal Medicine. A wonderful colleague will make a question to Professor Pittman so that we have him live with us.
Good day from Barbados. Thank you for an excellent presentation, Dr. Pittman. I just have actually two questions. For a patient with C2, C3, what level of compression, strength-wise and height-wise on the leg would you give? And also, living in a tropical island, my patients, I always tell them go to the beach, especially when they have edema. How often would you suggest they go into the sea for water therapy? 2-3 times a week? Thanks. Have a good day.
Chris, here we are live finally.
Thank you, Sergio. Excellent question, Dr. Patel. Knee-high compression hose are perfectly appropriate for maintenance. I typically advise 20 to 30 millimeter of mercury knee-high compression for maintenance here in sunny Florida. 20 to 30 millimeter knee-high compression gives patients a flexibility to wear two hose on one leg with pressure that is not quite additive, but increases the pressure to nearly 40 to 60. The patient may like more pressure all day or only part of the day, or on some days, but not others. Lower pressure hose that are less than 30 to 40 millimeters of mercury allows patients more flexibility to try different pressures without spending too much money. Sometimes only 15 to 20 millimeters of mercury will be tolerated or accepted by the patient, and again gives flexibility to wear two hose on one leg, approximating 30 to 40, as pressure is not quite additive. I advise all patients with severe lymphedema or edema, or certainly phlebolymphedema, to get in the water as much as possible. Not only is there compression, it activates a calf muscle pump, it supports joints in the spine in these older patients. Excellent question, thank you.
Thank you so much, Dr. Patel. And now it's my huge honor to introduce Professor Elena Goranova from Bulgaria and congratulate on the group for the wonderful meeting they recently held, indeed from Bulgaria in the Balkan Venus Forum. Elena.
Thank you, Professor Gianesini, for your kind presentation and for inviting me at this international meeting. Dr. Pittman, congratulations for your excellent educative lecture. You provoked me to think about the edema origin. Sometimes the differential diagnosis of the edema brings us to a difficult dilemma, especially in cases with presence of chronic venous disease combined with comorbidities such as cardiac insufficiency, long-sitting lifestyle, or lymphedema. What is your approach to this type of complicated edema? Do you conduct additional examination or investigation to define whether the comorbidities influence the patient's status? Thank you.
Excellent question. Of course, we consider these other possibilities and explanations that may cause or contribute to edema, such as organ failure, heart, kidney, liver, lung. However, in our patient population, it is extremely rare that a patient with these serious issues have not already been diagnosed. So both the patient and myself are typically aware of these comorbidities. Additionally, in our practice, patients with organ failure are very uncommon. I would submit the bigger issue is the under-recognition of phlebolymphedema, which affects far more humans on our planet than organ failure due to the prevalence of venous insufficiency. Regardless of contributing comorbidities, it is my opinion that all edema is evil and must be eliminated, regardless of cause or causes. My focus is my contribution to the patient's care as the venous and lymphatic expert. So I let the primary care physician or cardiologist and other specialists manage other potential but less common causes for edema. I would submit that any edema at or above the knee level is never simply phlebolymphedema. It may signal iliac occlusive disease, but more commonly in our patient population, it may signal organ failure, which is rare, or secondary lymphedema from prior surgery, usually for cancer. Or swelling edema above the knee may simply be primary lymphedema in younger patients. Finally, ambulatory compression is essential in all patients with significant edema, regardless of the etiology. So I will place them in Velcro wraps, which are relatively inexpensive and easy for the patient to self-manage.
Thank you so much, Chris. And now it's my time to be on stake, and it will be Professor Bottini introducing the two colleagues.
Thank you, Sergio. Let me introduce Dr. Brown, general practitioner from Jamaica. Dr. Brown, your question
Hi,
for Sergio.
I'm Dr. William Brown from Jamaica, practicing medicine for the last 35 years or so. Just wanted to ask one question, but that question is based on the fact that we in general practice, some of us see about 5 to 10% of our patients presenting with chronic vascular insufficiency and diseases. And sometimes there's a delay on our part to investigate these patients for better outcomes. So my question is that is there a way, or is it possible that we could use such a device in assessing our patients who we classify on the classification of CEAP, the C classification, from C0 to C2, if we can use this device on these patients so early so that we can identify the points of entry and leakage, so that we can help them in diagnosing them early and also referring them to the appropriate specialties like the ultrasound to identify those patients who we need to treat early so that we can give them better life and they can have a better quality of life. Thank you.
And I deeply thank Dr. Brown for this question that I received, of course, before, and I dissected a little bit. I think it is really offering us quite a lot of food for thought, because he said 5 to 10% of the patients who are coming into his office. Now we know it's far more in reality. So this is really giving you, I think, an evidence-based data on the importance of what we are doing today, for which I thank all the ones involved, because it is really far more than 5-10. It's more like 50-60% having some form of venous and a lymphatic issue. And I think it is also important that he referred to the CEAP as a sort of severity class that is really not, because we know that CAP is not a classification for severity. Of course, an answer usually is worse than telangiectasia, but this does not mean that telangiectasia, for example, in 26% of patients is presenting underneath some form of reflux. So it is very important to combine the clinical data also with on the history and also with the ultrasound aspect. So the answer to the question is absolutely yes in whatever clinical stage, because this is not related to the severity of the condition. Of course, other instruments could be used as well in advanced practice. For example, we use with pleasure plethysmography and also bioimpedance, but these are more advanced stages. But it is really important to be aware that the condition of venous hypertension is starting very, very early. There is a publication showing how already a C0S, so when you have just not even spider veins visible, you have already a decrease in the functional capillary density, showing that there is indeed an impact on the disease. So I deeply thank Dr. Brown for this. And now, Oscar, it's your time to introduce another special guest of the day.
Yes, it is my pleasure to introduce our friend, a thought leader, Professor Sasa Lazarashvili from Georgia. Sasa, whenever you're ready.
Thank you, Oscar, very much. Thank you, Sergio. Very interesting and excellent presentation. And of course, venous Doppler is the method that in all cases, practically all cases, don't need some additional methods to confirm the diagnosis that give the full information. And it was an excellent list of the golden rules. And I have the question according to last rule about the pelvic necessity of pelvic examination. My question is usually when performing routine venous Doppler of the lower extremities, particularly when examining the pelvic veins, the focus is on the common and external iliac veins. I think that mandatory examination of parametrial veins, which is very simple and takes only 2-3 minutes. For example, some parameters only like a diameter, presence of congestion or presence of tortuous veins, give us the information about the possible reflux from pelvis, or on another hand, if there is no reflux, give us the information about the condition of pelvic veins. What is your opinion about this?
Thank you so much, Professor Salvatore Lazzarashvili. Now, this is a moral call, I think, meaning that, as we know, this is an underdiagnosed, and it has been also defined as a forgotten disease, the one of pelvic reflexes. The incredible thing is that there is more awareness about asthma, of course, and back pain, but these two conditions have been recognized less present than chronic pelvic pain and the related pelvic venous disorder. So we really have to work, as we have had the pleasure of doing with you on this topic. For sure, the answer is yes, it's totally important. It is also important to visit experts like you, like Professor Ta and many other colleagues of the group, because up to my knowledge, we are still lacking standardization, as we said also the other day, in the proper evaluation, not just for reflexes that we are kind into the topic already, but in particular for the thrombosis of the region. We enjoyed yesterday a session together with Professor Lazzarashvili in which we were pointing out how 3% of all the women going to the gynecologist are presenting an incidental finding of a uterine venous plexus thrombosis. 3% every single day in whatever gynecological office. So again, it's our responsibility, I think, together also with the general practitioner and internal medicine doctor, to bring awareness, as Professor Lazzarashvili just did. So thank you so much, Salvatore, for this. And
Thank you.
And now we move forward with the educational journey. As we said, that this is a special Egyptian edition with a special representative, Professor Ayman Fakhri, a representation of the Egyptian Venous Forum. We will have his talk and then we will enjoy his contribution live.
Mr. Chairman, ladies and gentlemen, good afternoon. I am Ayman Fakhri, the president of Egyptian Venous Forum. I'd like to thank Professor Sergio Janisi for his great invitation for me to join the 4x4 education program. And now allow me to take my seat as your chauffeur to drive you to your final destination at multiple specialty approach and post-specialist evaluation. I'm going to discuss venous disease with orthopedics, physical medicine and rehab, obstetrics and gynae, neurology, nutrition, and lifestyle. Let's start by orthopedics. We all know the relation between fracture of the lower limb and plaster of Paris as a transient risk factor for provoked DVT. And Payment has published a very nice paper discussing the risk of venous thromboembolism in the orthopedic patient, epidemiological and physiological data in orthopedics in 1997, and came to the conclusion hip or knee orthoplasty or injuries could be associated with DVT up to 40% and fatal PE up to 1%. This is very nice demonstration and advice taken from Sergio to print this and put it in my office, reminding me about what Joseph Cabrini used to tell: never kill a friend and never treat a stranger. That makes me usually make an assessment for the risk factors for every patient using this risk assessment model and stratify my patient as low, intermediate, or high risk for developing DVT, and going to prescribe the appropriate prophylaxis measure for DVT and the duration for each, and anticipating the risk of DVT could be happen. Again, it is very important to know that the type of surgery, the type of surgical machine, duration of surgery could affect the risk, and the most appropriate for each patient is the elastic stocking for each patient in major surgery as grade 2C, and anticoagulation treatment or heparinization should be depend on a balance between risk of clotting and risk of bleeding. Every patient could have graduated stocking, but when we are talking about medical treatment, we have to balance the risk between bleeding and coagulation. Shift to physical medicine and rehab. We used to treat our patient of the DVT with absolute bed rest till the SCP guideline released and demonstrate that early ambulation for DVT patients improve the patient much and improve his status. That encouraged me with my fellows in Qura University to prepare for this work about the role of gradual programmed exercise in the management of DVT of lower limbs. And we came to the conclusion of the gradual programmed exercise program has a significant effect on lower limb edema improvement and facilitate a return to work. A few weeks ago, I was invited as a judge for this nice paper about the role of squat exercise improving symptoms in varicose veins, and the author came to the conclusion monitored and tailored exercise improve pain scale and edema in ladies with lower limb varicosity. Sergio has published a very nice paper about specially designed aquatic exercise protocol to reduce chronic limb edema. In his paper, he showed significant improvement in the range of movement for the foot, either in side-to-side or dorsal and plantar flexion. Again, in his design for the program, came to the conclusion of the reduction of the extracellular water of his patients with significant improvement of edema on such patients. Let's talk about the foot. This is the normal foot arch, and this is the flattened arch, and this is high arched arch. This is the normal one with very good venous turn and good circulation. Both this and this has impaired venous turn, and of course, it will depend on many factors to improve this circulation. Let us see if we ask the patient to have a photo print for his feet. This is very important to get a print of his feet and assess how the pressure points and how the stature could affect his limb. In a very simple maneuver, if we see this patient with abnormality in his stature and abnormal foot, with a very simple insole could improve his feet and get a very perfect circulation for the limbs. What about the neurology? Dr. Zambuzi assumed that there's a correlation between chronic cerebral venous insufficiency and multiple sclerosis patients. And this results in deposition of iron in the biomotor of these patients. This abnormality of the chronic insufficiency, venous insufficiency, may result from stenosis of the internal jugular vein. And he assumed if he could dilate this vein, the patient could improve dramatically. Going to orthopedics, going to the gynecology. As you all know, VT in pregnancy is more common than other healthy patients, and Garrier anticipated that pregnancy predicted by venous thrombosis published in the New England Journal of Medicine, and he notes that compared with healthy women of the same age, VTE is more 10 times than common antenatally and 25 more postnatally. Pelvic congestion syndrome represents about 10% of those ladies that visit the gynecology clinic, and it represents about 3.9 of all ladies in the United Kingdom. There's a very good correlation between venous drainage of the leg and venous drainage of the pelvis. And if you have an abnormality of the venous drainage of the pelvis, either in the pelvic vein or uterine veins or internal iliac vein, this could be reflected on the lower limb and developing varicosity. So if we see this picture in the gynecology clinic, this abnormal varicosity either here or here, or at the distribution, we anticipate the presence of connection between these varices and pelvic vein. So if we find abnormal varicosity, we have to look up for the pelvis and try to solve the problem from there. If we succeed to occlude this vein, we will have a very much improvement for his leg. As you know, in about 50% of the patients, pelvic congestion is asymptomatic, but don't forget, don't be shy to ask your patient about the postcoital pain that results in depression of the patient. And don't forget to ask him her about chronic pelvic vein that lasts more than 6 months, sparonia, dysuria, dysmenorrhea, and of course, postcoital pain and depression. And this is very good questionnaire released by VWIN Foundation in all these languages. And this questionnaire was very helpful to demonstrate this phenomena. Nutrition showed that varicosity more common in obese patients. And this type of nutrition that help to get a proper size. Again, sedentary life demonstrates that venous disease upgrade from 15% to 70% with this sedentary life. So we have to practice sports, but don't forget sport is like a drug, harmful or helpful. So please choose gentle rhythmic activation of the calf, progressive gentle leg muscle contraction, and with water involvement, this will be great. Please specify your treatment and your sport. And don't forget that you have to at least 1 hour per day to raise your leg or elevate your leg, and 6 days per week at least to wear your type 2 elastic stocking. All this could be done with social support and of course self-managed. What about the self-specialty evaluation? This is great. We heard that about 80% of varicose recur, and some people ask why we don't have varicose veins of our limb. Let's assume this is the effect of gravity in the limb. When we raise the leg, varicose is less common, and the effect of gravity is less common. When we raise the leg, varicose is less common. But if you stand like that, we anticipate developing varicose vein if we stand on our hands. Now, dear, general or internal medicine, you are the hub. And please remember, for follow-up, make sure the patient is compliant. Please, risk factor for follow-up determination, monitoring clinical changes, adapt the indication. For example, if your patient is going to have a prolonged flight, the risk factor will be changed. Make your differential diagnosis and monitor the family if the patient presents with genetic predisposition. Thank you for your attention. See you in Egypt very soon.
And
have a good day.
With this, we deeply thank Professor Fakhri. We start with the last car of the 4x4, and then we will enjoy his presence live. It is my deep honor and pleasure to introduce Rakesh Rambali, a wonderful colleague. For real, I had the pleasure of co-working with him. Is a great representative of the region from Trinidad. Here is his talk, and then we'll have him live with us.
Good morning, good afternoon, or good night. I am Dr. Rakesh Rambali. I'm a vascular and general surgeon in Trinidad and Tobago, and I would like to thank you to our presentation, like to welcome you to our presentation today on mistakes not to be made in venous lymphatic disease. I would like to take this opportunity to thank the organizers of this educational program, with a special thank you to Professor Sergio Giannisini, who was extremely helpful in getting this together. So, as you know, any patient who presents to us, we start with a complete clinical examination, which includes a history, physical examination, and appropriate investigations. And I would like to start basically with a simple clinical scenario. And as you can see here, this is a young lady who presented after having multiple episodes and admissions for cellulitis of her leg. She has a typical champagne glass with a small ulcer on the gaiter area of the leg. And she had multiple repeated admissions for this cellulitis and discharged. What I would like to first of all say, one of the common mistakes is that the absence of varicose veins do not imply the absence of venous reflux disease or chronic venous insufficiency. And also, a dilated vein is not always pathological. In taking our history, we should ask if there are any previous venous stripping or intervention, foam sclerotherapy, etc. Also, if the patient had previous intervention, it does not preclude that the patient may have recurrence of disease. And one of the common mistakes that are sometimes made is that the symptoms may be trivialized by attending physicians. And this sometimes leads to a delayed referral and sometimes inadvertent at increased costs. For example, patients with eczema going to the dermatologist, leg swelling with repeated admissions or referral to cardiologists, patients with tingling or leg cramps going to a neurologist. So I would like to say that we should start off by paying close attention to our patient and be cognizant of the fact that venous disease is prevalent in about 30% of the population. Its incidence is higher than coronary artery disease, malignancy, and peripheral arterial disease together. And these symptoms can sometimes be atypical. And we should pay particular attention to the risk factors of these patients, as some patients can have DVTs, especially in malignancy. Now, when doing our clinical examination, we should be as thorough as possible, looking at both legs. For in some patients, they may have superficial venous thrombosis, which may be unilateral, but the disease may be bilateral. And we should look for other symptoms or other signs that may suggest other pathology, concomitant pathology. Now, as mentioned before, some patients may not have visible signs of varicose veins, but this does not include the absence of venous disease. And in patients with superficial venous thrombosis, some patients may require anticoagulation, some patients may have obvious cancers. And remember not to treat patients without a complete clinical examination, as some patients may have severe peripheral arterial disease that we may want to treat prior to treating venous disease, as in this 84-year-old patient who presented with varicosities and an ulcer somewhat typical of venous disease, but on further interrogation, she had a severe peripheral arterial disease with a desert foot that we would not want to be too aggressive before treating her arterial disease. This young man here also presented with swelling of his legs and was diagnosed with lymphedema for 10 years prior to appropriate investigation. and a duplex scan showed he had severe reflux disease. So avoid the mistake of not considering lymphatic disease or venous lymphatic awareness in our patients. Now, as mentioned in the last case, imaging is key, and we need to have standardized imaging to avoid improper diagnoses. And this can be helped by sending to a standardized lab or standardized examination techniques. Now, I would like to say that we should pay attention to the possibility of concomitant pelvic venous disorders, just like we would pay attention to the possibilities of DVTs. Now, again, be wary that this can affect both male and female patients, and that the scope of problem is very, very high, and we should attempt to treat patients. Now, some common myths that also is that venous treatments are only cosmetic. As we know, treating some patients can lead to significant improvement in quality of life, and we should not avoid treatment based on the fact that it's simply cosmetic. Some patients would prefer to treat after pregnancy, not necessarily with our minimally invasive options. And insurance not covering the treatment may determine based on local or regional insurance policies. And I would like to end by saying that in venous disease, avoid the one-size-fits approach to all patients. And we should be cognizant that we should personalize treatment options, and that teamwork wins, to consider appropriate referral patterns where needed, whether it's a vascular lab, wound care specialist. And lastly, patient education. And all patients should be aware that this is a progressive disease, and that venous ulcer is not only served with one form of treatment, there are multiple, whether it be medical treatment, phlebotics, compression, and that office-based treatments may be suitable in this COVID pandemic era, as it avoids hospitalizations, and that the minimally invasive options are actually better tolerated by most patients. Thank you very much.
Thank you, Doctor. Now, Dr. Edward from Trinidad, General Internal Medicine. Dr. Edward, please, your question to Dr. Fakri.
Good day, everyone. Thank you so much for the opportunity for being a part of this webinar. Many thanks to our presenter for such an informative and interactive presentation. My question today is, does venous insufficiency increase the risk of DVT in patients? And if so, what measures can be, preventative measures that is, can be undertaken to prevent this? Thank you.
Professor Fakri, your time to go live.
Okay, thank you, Sergio. This is a very nice question. Thank you for that. You are asking about the effect of chronic venous insufficiency and how it may increase the incidence of DVT. Am I right?
Yes.
Yes, you have a point. Of course, chronic venous insufficiency is a real problem. And if we don't have a unique venous system and normally functioning venous system, we can anticipate the presence of venous disease and DVT. And if we go back to the risk assessment model of Professor Cabrini, you notice this was clear, and he gave varicose veins three grades. Also, in every risk assessment models, you can find this viscosity or venous insufficiency has increased points for predicting venous disease, and we have to go for increasing measures for thromboprophylaxis.
Thank you so much, Professor Fakri.
Now, once again, let me introduce our friends, Professor Sasa Lazarashvili. Sasa, go ahead.
Okay, thank you very much, Oscar. Thank you very much, Dr. Fakri, for such interesting and important presentation. Of course, we all agree that decision made by a multidisciplinary team often gives us a good result, but sometimes it's really ineffective. In your opinion, what are the main problems in the process of multidisciplinary management of the disease? Thank you.
Thanks, Sasa. This is very important and you hit the target. I like the discussion very much. Yes, multidisciplinary MDT is the key now for better practice medicine. As you see, we made a lot of cooperation with physical medicine, even if we can help the patient to stand up correctly and take a normal upright position with normal feet, we can help him a lot. Every time we meet with the gynecologist for thromboprophylaxis during pregnancy, it will be a very hot discussion. We meet every Monday with gynecologists, interventional radiologists, and internal medicine, and put a plan how to give thromboprophylaxis tailored for this lady during her pregnancy. And sometimes we hit a lot of problems. Sometimes they are afraid, the anesthetists are afraid for keeping on anticoagulation just a few hours before surgery. But using the proper guidelines and talking together and voting for each patient, we can take a proper decision and give the patient a better chance for getting better.
Thank you so much, Professor Fakri. Would you like to take this chance to tell us the next time we'll be in person together in Egypt?
Yes, I'm very happy to answer this question. This is great. We are expecting you all in Alexandria, Egypt in October, 10 to 13 October. Please prepare yourself and fix your luggage, and we are waiting to welcome you all in Egypt once again.
So let's hope that soon we'll be able to enjoy both the wonderful Central America, West Indies region as well as the Egyptian region. Meanwhile, we will enjoy the LATAF virtual bridge, of course. Now it's my pleasure to fly virtually to Italy for a colleague that in our region needs no introduction because he's our reference point for general and internal medicine. He's really a very well prepared colleague with his comment to Professor Rambali.
Hello everyone, I'm Francesco Bonetti, an Italian general practitioner. And first of all, I would like to thank the organizers of this event for the opportunity to participate in this confrontation, and Dr. Rakesh Rambali for the interesting presentation that touches several key topics in patient management. I'm glad to see that Dr. Rambali has stressed the need to frame the suspect vascular disease in the context of patient's history and clinical characteristics. A good, complete clinical assessment is cardinal, especially to prevent the fragmentation of patients' clinical path, as evoked by Dr. Rambali, that warned us against the inappropriate referral. Referral to countless specialists could be confusing or even harmful, and containment of useless prescriptions and investigations, also defined as quaternary prevention, is an important objective in general practice. The longitudinal point of view on patient clinical history of the general practitioner could be an adjunctive value to bring in the collaboration with the vascular surgeon. Moreover, I think that in this era of chronic diseases and clinical complexity, the whole patient personalized approach has to become the new standard, even in ultra-specialized settings. to achieve a correct biopsychosocial framing for the patient and to merge the specialistic prescription with the patient frequent polypharmacy and comorbidities, the collaboration between surgeons and internal medicine specialists or general practitioners could lead to great improvement in the cure. Even if not immediately linked to local venous lymphatic condition, prevention of local repercussion of systemic inflammatory and metabolic diseases through adequate control of the underlying condition and timely diagnosis and treatment is surely a field that benefits from multidisciplinarity. Last but not least, promotion of an adequate compliance to the prescription concorded with the specialist is surely a feature that general practice could bring to the table, because as I'm sure you all are well aware, many therapy failures are due to prescriptions discontinuation. And the general practitioner is the right figure for contributing to isolate the personal, clinical, and social environmental factors that contribute to poor compliance and to implement possible solutions due to the frequency of consultations and knowledge of the patient reality. All these factors sustain the need for collaboration, starting with formation events like this and passing through information technology implementation to share patient details via local and national databases, reaching a direct communication channel between specialists and territorial realities for more tailored approach to the patient. Thank you all for the attention and goodbye to everyone.
Well, thank you, Dr. Bonetti, for what was a call to action, I'd say even more than a comment. And Professor Rakesh, if you are here, if you'd like to make some further comment, unmute yourself.
Hi, thank you, Sergio. Again, I would like to say most of the speakers, I'm in full agreement with their comments. Thank you, Professor Bonetti, Dr. Bonetti, for again your succinct conclusions. Basically, just to reiterate what my colleagues just said, Dr. Pittman, I think a clinical examination, put a hand on the ankle as picking up edema. I agree completely. It's more likely to be phlebo edema rather than organ failure edema, as we tend to underdiagnose venous insufficiency and hence we undertreating patients. Dr. Fakri, never treat a stranger again. Continue to examine our patients, personalized treatment, do proper scans. So pretty much a full agreement with what my colleagues said before.
Perfect. Thank you so much. And now we fly on the way to Russia for the question from Professor Zolu talking Igor, another pillar in our venous ward.
Dear Rakesh, thank you so much for a nice presentation. You mentioned that minimally invasive office-based treatment is much more preferable in new COVID-19 era. But what do you think about diagnostics? Maybe we should abandon a face-to-face live way of diagnostics as we do now. Maybe we should use such technologies as Zoom or Skype to communicate with patients and to find what they have, to confirm their disease, because it's not that difficult to talk to patients like we are talking to each other now. What do you think of this? Do live visits are also myth of venous lymphatic disorders or not?
So can you approach a patient like if it was your friend, as Caprini saying, Rakesh, by an app?
No, I agree with the comments actually. Given the COVID, especially during spikes or waves where you have high incidence, video consultations is probably preferable. The video consult can do just pragmatically assess whether it's something that's urgent or not urgent. Venous insufficiency in most cases is not life-threatening, but remember that venous disease is progressive. As my colleague before said, recurrence is as high as 80%. I do believe, and I have been using it in my practice as well, a lot of video consultations. I can use this to prioritize patients. I can defer patients to when it's, you know, make sure they are low risk for spreading or contracting COVID. But for the diagnostic aspects, most of it will require the patient to come in to have maybe a venous duplex. I don't think, in my practice, I do see a lot of C5 and 6. They do have recurrent ulcers. Those patients I do tend to bring into the office so I could advise them and you know, start treatment as soon as possible. C1, early disease, C1, C2, I do believe we can, because of the COVID, try to treat due video consultations.
Okay, thank you so much. It's 6:16 in Italy. It's the perfect time to virtually fly all the way to Central America for the greetings to West Indies, because as you know, we are promoting also, of course, a synergy in the region of West Indies and Central America, as well as collaboration with internal medicine and general practitioners, globally speaking. So here is Dr. Cabeza, a wonderful colleague from Costa Rica. Greetings to our colleagues of West Indies.
Hello, hola, ¿cómo están? Greetings from Costa Rica. I'm Dr. Javier Cabezas, vascular endovascular surgeon. I want to give a very special thanks to the Big Wing Foundation, the coordinators of this great initiative, the 4x4 project, Professors Gianicini, Bottini, and Chi, as well as the sponsor for considering Central America and Caribbean for including us in this academic activity that I'm sure will be bring benefit to the participants. I want to congratulate also the speakers of these lectures that show the need if we want to try to achieve success in the diagnosis and treatment of our patients with venous and lymphatic disease. We must combine the basics principles learned as doctors, such as talking a detailed medical history and physical examination, using information available through the different guidelines such as SEAP and others that we have at our disposal, and they are universal use, and the importance of the use of the venous ultrasound or similar device that, in my opinion, is part for the path to the successful diagnostic, planning of the treatment, and follow-up of our patients. The comprehensive management of the venous and lymphatic disease should include the work on multi-specialties, and all above, in my opinion, can help to avoid errors of the diagnostics and treatment as much as possible. Greetings and pura vida. Ciao.
And we say pura vena, pura vida as Professor Grillo taught us, and it's my huge pleasure to now fly all the way to Guatemala for Professor Merida. Greetings once again from Central America to West Indies. Pepe, if you want to open your mic, I know you are with us.
Yes, thank you very much, Sergio. And thank you very much for the honor of representing my country, Guatemala, and my region, Central America, in this webinar directed to West Indies. I would really like to thank all these excellent faculty you put together. And I hope it achieves the main purpose of the webinar, that is to instruct or help the general practitioners and internal medicine to work together in detecting follow-up and treatment of these patients with chronic venous disease, which is a very prevalent disease all around the world. These were excellent talks, and even I learned a lot from them, and I hope these collaborations keep going on. So thank you very much, Sergio. Thank you very much, V1 Foundation, and thank you very much, Servier, for the collaboration in putting this webinar together. Thank you very much, everyone.
Thank you so much, Professor Merida. We look forward for being in the land of the eternal spring, as Guatemala is called, for your next educational initiatives. We now give the mic to the audience. So let's have a look at what we have in the question and answer box. I see Charles Greenedge is writing, as regards pain, some patients who have pure venous disease, no arterial disease, get more pain on elevation. Why and how to deal with this? Chris, while you're warming up, I will try to give my answer to this, and then I will pass the mic to you if you are still with us, or if not, Rakesh or Ayman, since we are like the one involved in this session. I would say that this question that pathophysiologically is quite intriguing, because indeed it should be the arterial component given this kind of pain, is offering us the opportunity to brainstorm with internal medicine and general practitioners on the fact that symptoms and signs in venous disease are extremely frequent, but extremely also aspecific. So as we have pointed out in this webinar, the multi-specialty approach is fundamental. As Professor Faikri pointed out, many times there are also postural issues that are coming into the game. And indeed, we have seen how the risk gets increased by 4 times when we have a postural defect. So in this scenario, you want to be sure, for example, that you don't have some postural or spine defect that is giving you a LASEG positive maneuver. It is very important for the internal medicine and general practitioners to know that when there is an answer, 1 out of 5 is actually presenting a multi-component origin. That is another evidence of, I think, what I just said. So my suggestion, Charles, would be to really look at 360 degrees the patients to make sure that it's not maybe just venous, but that there are like also other components involved. I don't know if Ayman or Chris or Rakesh would like to take the mic. And I see we have still with us Matt Josnan, who I deeply thank for being with us all the way through. So if also Matt wants to take the mic on this, feel free to do that. Anyone wants to take the mic?
Okay, Sergio. This is a very good question, and she's asking why leg elevation increases pain in arterial cases and relief pain in venous case.
No, I think that yes, patients who are having pain when they are elevating, even if they have no arterial component.
Yes, she doesn't have arterial component, but still have pain on raising leg. Yes, sure, this could not be related to back spine, neurological origin. I think this is very important to check for her back and check for proper neurological examination. I think this will be a clue for this patient.
Thank you so much. Matt, I see you're there. Would you like to make any comment from France? Unmute yourself.
Sorry,
we are talking about a patient who is having pain with leg elevation, no arterial disease, just the venous. So we suggested multi-specialty evaluation because there could be some postural components. Would you agree with this? Or?
Yes, I totally agree with this. It's probably a another diagnosis, and so we have to address this patient, to refer this patient to another team to complete the diagnosis. Yes.
This is an interesting question, I think, because it's offering us opportunity to brainstorm with the general practitioners on the fact that compression, for example, graduated compression that is usually considered contraindicated in arterial patients, we demonstrated also recently might actually be of help because mainly of the edema management, of course, with proper prescription. But of course, being careful in not having the patients lying down, because there was a recent publication a few months ago by Rather really showing that you don't want to have the patients lying down, but like standing up. And in those cases, we demonstrated with another publication, you can have a better oxygenation of the leg. But now it's time to go big for the big finale with Professor Wasila Taha from Egypt and their honorary lecture. I know that Wasila is with us and she will share the screen for her 8-minute talk, right?
Right, absolutely right.
Yeah, we are. Welcome, Wasila.
Thank you so much, Sergio. Thank you so much, Oscar. I'm truly honored to be today, and my honor is multiplied today being invited to deliver the honorary lecture. It's a huge honor, a huge opportunity. Thank you so much. Now, I would like to share with you my presentation entitled Differential Diagnosis in Venous and Lymphatic Disease. I have no disclosure. And Arabs, as Ibn al-Nafis and so many scholars, really they early paved and pointed to the venous and lymphatic disease. And vein and lymphatic disease surely deserve such important and prominent attention. If you look to the Webster dictionary, what is meant by the word differential diagnosis? It is to distinguish between several clinical conditions from others presenting with similar signs and symptoms. So the key word here to differentiate between signs and symptoms. As all we know, SEAP, it's a sign classification. And I would like to stress here on the lower limb edema and the devastating skin pigmentations up to the active ulcerations. This is an important document by the International Union of Phlebology in 2013, and Professor Bibeli and the co-author stated that lymphatic failure is responsible of all forms of peripheral edema. And in a recent publication by Tony Gasparis, here they noted that the lymphatic system, regardless the underlying pathology, has been underestimated and what we call usually the hidden epidemic. As all we know, the primary lymphedema has 4 stages, very early, the pitting one, up to the devastating and maybe irreversible stage 4 with a lot of fibrous tissue. But the vein and lymphatics, they're a really inseparable couple and what we call the phlebo-lymphedema. This is very important study with a large cohort of patients in Ohio Physiotherapy Clinic by Professor Stephen Dean, very recent publication last September. And it came up with the robust data that the secondary lymphedema is caused by phlebo-lymphedema in 36% of incidents. This is what totally we thought before, that the cancer is the first incidence and the highest incidence caused the secondary lymphedema. But this robust data nail and confirm that the phlebo-lymphedema show the highest incidence. This is typical clinical example here. The stasis with hyperpigmentation consists with chronic venous insufficiency. Here, what we call the inverted champagne bottle shape. The swelling of the foot consists with lymphedema, and this is a typical classical example of the inseparable phlebo-lymphedema, what we see in our daily practical practice. Even the old literature, Hammond and Wessler in 19s, also they showed that the extremities with chronic venous insufficiency had an abnormal lymphoscintigraphy. Let's go to the clinical background. Here we have 2 clinical scenarios, the lymphedema versus lipedema. For the lymphedema, there is always foot swelling, while in the lipedema, the foot is sparing, what we call the cut off of the ankle. Lipedema is almost and very often symmetrical, and the mismatch of the body proportion, what we call the pear-shaped body shape. And sometimes it's very painful and cannot relieve with leg elevation. And also we have the hybrid scenarios. So co-factors could coexist together. Here we have the focal protuberance of fat, a foot swelling, while the other limb had what we call the ankle cut off with no foot swelling. And this is typical a lipedema with secondary lymphedema. Another scenario with the coexisting multiple factors, we have the mismatch of the body consists with lipedema, the foot swelling consists with lymphedema, but also we have the hyperpigmentation along the leg, which determine the venous stasis with hyperpigmentations, which consist with chronic venous insufficiency. This is lipedema with secondary phlebo-lymphedema. Don't forget that the clinical scenarios could be unilateral or bilateral. And also the clinical scenarios could be acute onset and chronic onset. For the bilateral lower limb edema, I think our dear colleagues here, the general practitioners and the internal medicine doctors, they are very familiar with the systemic causes, cardiac failure, hepatic failure, renal failure, hypoproteinemia, allergic disorders. And in this basket, we have to go a workup of laboratory investigations as well as an echocardiography to set the diagnosis. And another important basket also on a daily practice, we can find patient with drug-induced bilateral lower limb edema And on the top of the list, the antihypertensive drugs and the family with calcium channel blocker, and very familiar with the apomorphine and enalapril. For the unilateral swelling, the list is long. The chronic venous insufficiency is all we have learned, beautiful and outstanding presentations, the primary varicose veins, all secondary with post-thrombotic limb, hematoma, congenital malformations, arteriovenous fistula after trauma, rupture Becker cyst. We confound very much the acute onset of pain and swelling of unilateral lower limb edema could be rupture Becker cyst or popliteal aneurysm, really exerting an extraluminal compression on the nearby vein. But when we are talking acute onset and unilateral, we have to think acute DVT, provided whatever the cause until it is proved otherwise. While we are talking about the chronic edema and standing to the side, mainly on the left lower limb in a female with a middle-aged female, we have to think May-Turner syndrome, where the left common iliac vein is compressed by the right common iliac artery, and this is, we cannot miss that. Well, this is the typical clinical scenarios we see it, and the edema could be really with a proper physical examination could be set the clinical diagnosis. Coming for the devastating skin pigmentation ulcerations, here we have to differentiate between venous leg ulcer and ischemic ulcers by their really position or the morphological distribution, but also have sometimes very resistant ulcer, vasculitis, and malignant ulcers, which cannot be diagnosed until we get biopsies from those ulcers. The GREAT project, we really enjoyed the GREAT project, and it comes up with a very informative knowledge about how to differentiate between ischemic ulcers and venous ulcers. We have to set the bedside investigation, the ABI, the toe pressure, the velocities at the ankle, and how to differentiate between ischemic ulcers and the neuropathic ulcers, which is very different on their morphology, as it is the pressure points or inducing those neuropathic ulcers. And coming to the venous leg ulcers could be at the ankle level, could be on vast majority at the medial side, or maybe also on the lateral side of the ankle. We have in 2021 really a wide range of diagnostic modalities. We have the duplex ultrasound, we have the MR venography, we have the CT venography, the IVUS, as well as the lymph scintigraphy. Here, lymph scintigraphy confirmed what we called the phlebo lymphedema. Here we have the skin pigmentation of the leg consists of chronic venous insufficiency, but also we have a stasis. Here, the lymph scintigraphy, we have lymphostasis corresponding to a lymphedema element. And the MR venography and CT venography, they are very useful whenever the ultrasound cannot get a proper diagnosis for the proximal occlusive disease, either post-thrombotic, the native veins themselves are occluded, or extraluminal compression as in the May-Turner syndrome. But the ultrasound is the mainstay, being non-invasive, available with no harm of contrast and cost-effective. And moreover, the guidelines, SBS and American Venous Forum, show that the first diagnostic modality for chronic venous insufficiency could be the ultrasound with the highest level of evidence. Here's some example when the patient had an acute onset of unilateral leg pain. It could be a popliteal aneurysm and really exerting extraluminal compression on the nearby vein. It could be a Becker cyst, ruptured Becker cyst, or it could be a muscle tear with the history of sports, an aggressive movement with the sports. And here we can see the collection of the fluid inside the muscle itself. All it's beautifully illustrated by the ultrasound. But once again, the acute onset unilateral swelling, it should be to confirm acute DVT until it's proved otherwise. And this is a beautiful image with the acute DVT, distended vein, and the nearby of the artery. So this is a distended vein consists of acute DVT. But also the ultrasound can really make the decision for the underlying refluxes, is it present or absent, and also the occlusive disease, mainly for the femoral veins and the iliac veins, which really confirm and make the decision making totally different for plan of treatment. But also the beauty of the ultrasound can really pick up the systemic causes, the ascites. Here in an example of ascites could be an hepatic failure and could be also the congestive heart failure. But here also with the pulsatile, highly pulsatile Doppler spectrum, it also consists with congestive heart failure. So to conclude, the venous and lymphatic disease are really inseparable. The highest incidence of secondary lymphedema is phlebolymphedema, lymphatic failure, the underlying the cause of all sorts of edema. The hybrid factors, varieties of etiologies could coexist together, and careful history and physical examination are essential. Selection of the cost-effective appropriate diagnostic test at the ultrasound, and the onset is very important, and also unilateral or bilateral edema is of paramount importance. Thank you for the opportunity, and we feel that VWIN meetings are truly our personal meeting, and this is what I call success. Thank you so much.
Is us deeply thanking Professor Ta for a truly brilliant talk that was in a difficult position because the previous week was Professor Caprini, but I have to say you are second to no one. And indeed, to honor you, we have the huge honor of having with us a huge representative of the vascular field, Professor UNC from Malaysia, from Putra University, an institution among our friends and colleagues, and he's really giving us a huge honor because it's really over midnight in Malaysia, and he's here with us live for honoring Professor Wasila Ta with his contribution. So Professor Liu, if you'd like to share your screen and go with your comment and question to Professor Ta. Unmute yourself. And see?
Yes.
Here we are.
Can you hear me?
Yes, perfectly. If you want to share your slides. He's always preparing a precious material for these education activities, so we really want to enjoy this.
I couldn't get my slides. Why don't you play the video?
Okay, so we go with plan B, no problem, then we will have you live. Here we are.
Hello, this is Dr. Liu from Malaysia. I'd like to thank you for the privilege of participating in this 4x4. And I'd like to thank Wasila for an excellent presentation. She has highlighted the importance of diagnosing lymphatic component when you're faced with a chronic venous disease. And we all know in a chronic venous disease, when you have the interstitial fluid accumulation that overwhelm the capacity of the body to drain out this fluid, the lymphatic component is also compromised. And instead of commenting on the lecture, I'd like to share a case here to see how we can apply what Wasila has said into the management of this case. Now, this is a very interesting woman who is 79 years old, who came to see me because she's got a chronic left lower limb swelling. And so when you look at this left lower limb swelling, certainly the hemosiderin pigmentation and the swelling would alert to you that she has got some chronic venous disease component. But looking at the swelling of the dorsum of the foot and also the folds at the ankle, they will remind you that she may have a lymphatic component. But in real life, patients are not easy because they do have many concomitant problems. And for this woman, she has been having this chronic leg swelling for about 6 years, and she has been repeatedly admitted to hospital with recurrent cellulitis. And she's diabetic, hypertensive, with renal impairment, hypothyroidism, giant cell arteritis, anterior resection for CA colon, osteoarthritis of knee, and old fracture femur. Now, those things that are highlighted here, like renal impairment, hypothyroidism, anterior resection for CA colon, osteoarthritis of knees, old fracture femur, etc., all this would have resulted in the leg swelling. And so, whether it is a venous component that's dominant or the lymphatic component is dominant is something that we need to investigate. So this woman is subjected to a duplex scan, like Wasila said. That's the mainstay of diagnosis. And so we found that she actually has got a deep vein incompetence, the iliac vein, common femoral vein, and superficial femoral vein. However, going down to the popliteal and tibial vein is very difficult because of the gross swelling in the foot. And she also has a reflux in the great saphenous vein for up to about 1.5 seconds. So she does have a chronic venous disease with reflux in the deep and superficial vein. And what about the lymphatics? Well, we did not investigate further on the lymphatics because I don't think so a lymphoscintigraphy would help in the management of this patient. So she came back in one of the episodes. You find that, as I described to you, there's gross edema in the leg. There's a lot of folds at the ankle that suggest this got a lymphatic component. And she has now developed an ulcer over the posterior aspect of the leg. I think it's due to edema and also perhaps due to the pressure when she's lying down. And the component here, this infolding, etc., will suggest to you there's actually a lymphatic component. So how shall we manage this patient? Do you want to put her on some kind of compression garment alone? Or would you want to go and manage the superficial vein incompetence, or maybe consider her for some deep vein reconstruction? Or would you send her to some kind of a manual lymphatic drainage? Well, in this woman, what we did was we actually sent her to this manual lymphatic drainage and then put her on some kind of a compression bandage. And we actually encouraged her to walk rather than just sitting down on the wheelchair every day due to her osteoarthritis of the knee. And what surprised us was in one of the episodes, she actually came to the hospital, and then she was treated for her fluid overload due to her chronic renal disease. And when she was resting in the ward with intravenous furosemide, she actually improved. And in fact, the leg came back to almost, the normal compared to the contralateral side. And I think certainly this would tell us that perhaps the venous component is dominant here, because if it's a chronic lymphedema, perhaps the leg swelling would not subside so rapidly. And so the question to Vasila is, how will diagnosing a lymphovenous disease rather than chronic venous disease alone impact the management? And how will we manage this patient? With that, I thank you very much.
And it's us deeply, deeply thanking Professor Liu for his contribution. We have Professor Ta answer, and then we have a rebuttal from Professor NC.
Yeah, thank you, Professor NC, for the nice words, and also I would like to share just few slides, Sergio. Don't worry, it's just few slides. Thank you so much, Professor NC. And congratulations, this is the challenging case with long list comorbidities. And as you mentioned, the clinical diagnosis is very important. Ultrasound is what the mainstay, but I will stop at this slide. Your ultrasound findings, let's say incompetent deep system, but the incompetency of the deep system, we didn't know is it the primary or secondary. It is obstructive, underlying obstructive lesions or occlusive lesions, because this will change the map or the decision of treatment, and in the presence of the GSV reflux. And very importantly, you have mentioned that the popliteal vein and the tibial vein, they were not interrogated. I think the distance between the posterior tibial veins and the superficial veins at the gaiter zone with such pigmentation and with such ulcerations at the ankle level, where the true high venous pressure is transmitted, should be examined and thoroughly examined. And in our team, we do with this on standing position and a probe on cross-sectional and perpendicular, sometimes cross-sectional and perpendicular to the posterior tibial veins, and sweeping from down from distal to proximal, you can get the posterior tibial veins despite the presence of this significant edema. I will start with the second question, how we manage. This is maps in our patients. It's typical if you have a JSV reflux and with such ulcerations, according to the EVRA trial, the recent trial, we ablate this JSV provided that the JIP system has no occlusive or secondary refluxes. And we do ablation of the JSV and foam sclerotherapy. So this patient was treated radiofrequency with foam sessions with the underlying superficial varicosities at the vicinity of the ulcer. If the ultrasound findings give us that the findings of the incompetency of the DIP system is due to, and the underlying pathology here, occlusive disease, we never touch this JSV reflux, but we will go to ablate the superficial varicosities at the gator zone. And of course, the compression will be one of the main important line of treatment. Just to differentiate with the secondary phlebital lymphedema, yes, by the ultrasound, we can detect the edema. This is a typical example with the interstitial edema from Cavezzi, and this is our own work on our team, and we can really get the interstitial edema, and it would be also a good prognostic tool. So you measure this thickness, you measure this interstitial edema, you apply your compression, and during the follow-up scans, you can measure if your patients really get a benefit and significant cure, significant benefit from your line of treatment or not. Thank you for the huge opportunity. And this is your assistant. I know your sonographer, Wendy Wong, and I know she is a huge professional. Please, Dr. NC, convey my best regards to her. She helped me a lot with the broken leg in India, in Chandigarh in 2017. Thank you so much for the opportunity. Thank you.
And thank you so much, Professor Ta. Would you like to have a rebuttal, Professor Liu?
No, I think Wasila has explained everything quite clearly. The only reason why we did not want to intervene in this woman, because she has got multiple comorbidities, chronic renal failure, and she has had a fractured femur, osteoarthritis of the knee, so perhaps she may have associated a post-traumatic limb syndrome, etc. So as long as you could heal the ulcer, get the leg a bit better, and I think for the time being, she's quite happy with it. She's already 79, and I think we leave it as it is. However, if the ulcer recurs, then perhaps I'll follow exactly what Wasila says. And once again, Wasila, thank you very much.
Thank you,
Perfect.
Professor NC. Thank you.
And thank you again to all these two giants. Time for another giant from Egypt, Professor Bishara. We deeply thank for all the efforts together with Professor Ta on the lot of projects. And here is his final remark. Professor Bishara.
Well, thank you very much, Sergio, for the great honor to participate in this elegant educational webinar. And let me share my slides. In the next few slides, I'm going to try and summarize the most important message from each of the four excellent presentations. Well, today was about diagnosis. The first presentation was from Christopher Pittman of Florida, state of the art in clinical consultation. Well, he emphasized a new concept, and that is monitored hose trial, whereby a hose is given for a patient 2 days off and 2 days on to try it and see what happens. He also talked about venous disease being very common and also very commonly overlooked, and hence the great importance of having a thorough history and clinical examination. Dr. Sergio Giannassini's presentation was really not only scientifically very rich, but really it demonstrated that art is embedded in the genes of the Italians. Every slide contained a lot of art. He emphasized that venous disease is indeed very common, and that patients with venous disease should have a proper Doppler ultrasound, and that this should include identification of the details of flux, identification of obstruction all the way up to the heart, recognition of pelvic venous disease, and all the potential sources of reflux should be properly assessed. He also explained the importance of femoral vein reflux on recurrence at the junction, and he explained that not all outward flow from the perforators should be considered pathologic reflux. Dr. Ayman Fakhri of Egypt demonstrated the interaction between venous diseases and various specialties. He explained the high probability of developing DVT in association with fractures. He explained the importance of programmed exercise on symptomatic improvement in venous thrombosis. He emphasized the high prevalence of venous thromboembolic disease in pregnant ladies and in postpartum period. He showed the potential connection between varicose veins and pelvic venous disorders, and he concluded that healthy foods and exercise is the way to a healthy venous system. Dr. Rambali from Trinidad talked about mistakes not to be made, and he showed that the most important mistake is to omit full history and thorough clinical examination. The honorary lecture by my colleague, Dr. Wasila Taha from Egypt, was really outstanding and remarkable. She clearly showed that lymphedema and venous diseases are inseparable, much like Antonio and Cleopatra, and that the most important cause of lymphedema could be indeed venous diseases, which contribute 36% of lymphedema patients. Finally, I would like to thank Sergio and the UN Foundation for the opportunity to participate in this elegant webinar. And on behalf of EVLA, we deeply appreciate our cooperation with our colleagues from Latin America, and we welcome our new collaboration with GPs and internal medicine colleagues from Latin America. Thank you, and see you next Sunday.
Thank you so much to Professor Rachel for always being an example of being a gentleman and a true professional. Now we move forward. We will have a little change of plan because Will is misbehaving, so we will have Professor Zaza taking his place, but now it's time for Oscar for final remarks.
Thank you all for excellent conference, good question, and brilliant comment. Due to the time, I will not be able to comment. Everything has been said. I want to stress out the importance of the collaboration from South and Central America with West Indies and Egypt and our dear LATAF, as well as the importance of synergy with internal and general medicine with our specialty. Like Will said, good morning, good afternoon, good evening, Willie. See you in Buenos Aires in September, and long live Lionel Messi.
And this is not Will, of course, because he's misbehaving, so we are torturing him with different jokes, but it is a very serious finale because Professor Zaza, also known as Salvatore among friends, Lazzarashvili is really a pillar in education worldwide, and we'd like to deeply thank him for his first-line involvement in this project. Zaza, would you like to make a final comment?
Yes, thank you, Sergio. Personally, I hope all faculty and all attendees are very satisfied with this webinar as previous webinar. And my question during the webinar was what is the problem between multidisciplinary approach sometimes. And I think that the main problem is to create a common language, to speak on common language. And I hope the previous webinar and this webinar and the future webinars also will increase the awareness and bring the stronger relations between vascular specialists and the primary care doctors. Thank you for
Thank you so much to you, Professor Salvatore Lazzarashvili, once again for the great contribution, in particular in this 4x4 project. We'd like to take this chance to remind everyone that it is open, the submission for abstracts at the Buenos Aires meeting where the world will gather together next September, and where the world started to gather together for our group, thanks to Professor Bottini, who we'd like to deeply thank once again for having initiated these group efforts that is involving professionals from all around the world. I'd like to deeply thank the ones in particular from West Indies and Central America for this project. And I'd like to deeply thank in particular Professor Merida, who will be the head of the next VHELP mission in Guatemala. We were planning to go there before the pandemic. For sure, we will go there as we did in 2019 in Santo Domingo, for which I'd like to deeply thank all the ones who have been already involved in this project. I'd like to deeply thank once again Servier for having supported in an unbiased way this experimental initiative addressed to the general and internal medicine. I'd like to deeply thank all the Egyptian friends and colleagues for this special edition dedicated to Egypt, and in particular to the LATAF bridge. So I'd like to deeply thank once again all the ones involved in creating a teamwork in a moral way in education. I think morality is indeed in fighting fake news and promoting evidence-based advancement in the field. So I'd like to deeply thank the more than 70 societies involved already in the project that will lead to the creation of a consensus document on the topic presented in the spectacular venue of Dubai during the once-in-a-lifetime opportunity of the Universal Expo. Just some different finale for today, because we have a big finale, of course, in few hours from now. So some words for my English friends who we are going to face in a few seconds. I've just got information of sad news in reality, because today also, always in England, Wimbledon, there was the first chance for Italy to win the final of Wimbledon with Berrettini as a player, and he lost actually during this webinar. But also thinking about it tonight, I'd like to remind everyone the nice sentence from Kipling that he is reported at the entrance of the major court of Wimbledon. If you can meet with triumph and disaster and treat these two impostors just the same. So it's really not about winning or losing, but about enjoying teamwork and advancement as we have done today, for which I'd like to deeply thank once again all of you, and inviting you to join us next week again. Thank you and enjoy.
Bye-bye all.
Bye-bye. Thank you so much. Thank you. Wonderful.
Thank you.
Bye.
Bye-bye. Bye-bye.
Bye.